Good day, everyone, and welcome to the Primary Care Resilience WebEx number 4 call, hosted by Jill Gillis. My name's Sheila, and I'm the operator for today. During the presentation, your lines will remain on listen only. If you require assistance at any time, just key *0 on your telephone, and a coordinator will be happy to help you. I'd like to advise all parties this conference is being recorded for replay purposes. And now I'd like to hand over to Jill. Please go ahead.
Okay, thank you very much for that, Sheila. Good afternoon, everyone. My name is Jill Gillis, and I'm the Portfolio Lead for Primary Care within Healthcare Improvement Scotland. And I'm absolutely delighted to welcome you all this afternoon to our 4th WebEx in our Primary Care Resilience series. We deliver these, as you know, in partnership with our CGP through Dr. Scott Jameson, who is the Quality Officer for the College, and with our colleagues in Scottish Government, with Dr. Michelle Watt, Medical Advisor within the Primary Care Division. Next slide, Sheila, please. Okay, and perhaps the next slide, Sheila. Fabulous. So in today's session, we want to continue to reflect on what we've learned in and around our responses to COVID and continue our conversations and continue that sort of connecting and learning from each other, which we've been doing through these WebExes and some of the follow-up information that we've been sharing through the discussions that we've been having. Today's session, we're focusing on managing long-term conditions in primary care, and we're going to discuss different ways of supporting people with long-term conditions. Next slide, please. But before we do that, I wanted to take a wee bit of time to remind you that these WebExes are just one component of our primary care learning system. As many of you will know, we produce evidence summaries, case studies, and we support networks such as our Community Treatment and Care Services Network. We're thinking that actually perhaps through the discussion and the interest that we've had today in and around managing long-term conditions, we may look to, and you may wish to form as a network, and we certainly would be keen to support the facilitation of that. We also provide responsive and bespoke improvement support through our primary care quality improvement faculty members, and all of these resources can be accessed through our platform Improving Together Interactive. Next slide, please. Thank you. So, as you all know, there have been significant changes in response to COVID-19, and we within the primary care improvement portfolio within HIS completed an extensive review with our stakeholders, and a number of you will have been part of those interviews and those sort of focus groups that we facilitated to identify our immediate national improvement support priorities. And following that exercise, we've identified 2 key priority areas for improvement support, and those are care navigation, and for us to work with practice teams across the country to support care navigation and including navigating to self-care, NHS Inform, and the recently launched Pharmacy First service. But we'll also continue to support some of the some practice teams in and around the use of tools such as Near Me. And we also will be looking to reconvene our pharmacotherapy collaborative, but really to take that beyond the scale that we've been doing with those collaborative participants, and to be supporting at a broader scale to focus on serial prescribing and work with practice staff to support moving as many patients as appropriately and safely possible from repeat prescriptions onto those serial prescriptions. So those are 2 key areas that we're keen to work with you over the winter, and certainly be in touch with you in the coming weeks. And all of this will be underpinned by our learning system. So on Improving Together Interactive, we'll continue to share what we're doing in these areas, but we'll also continue to share through our WebExes, and we'll have specific WebExes in relation to those 2 specific interventions. Next slide, please. So we ask you every WebEx to give us some feedback. We're keen to continually improve what we offer here, and we were told you do really find the topics, and I think that's partly because we ask you which topics you find these very useful and interesting, the mix of presenters. Every time you tell us it's too much information, too rushed, and we try and address that. We do genuinely have a lot of interest, and there's lots to cover in this sort of hour. So we've tried to address this sort of sense of rushedness, and hopefully we will be be able to keep this to time this session and have enough time for the discussion. Next slide, please. In that sort of feedback, you can see here that long-term conditions was one of the areas that you were very keen to discuss, which is why we have it on the agenda today. Next slide, please. I am now looking to introduce the next sort of series of presenters that we'll have for the next sort of 20 to 25 minutes. We'll start with Dr. Nico Kronenberg, who's a GP from Tayside and Cluster Quality Lead, and Nico will then hand over to Lynn Innes, who's General Practice Nurse and National Coordinator for General Practice Nursing within NES. We will then hear from Dr. Graham Kramer, GP and Clinical Lead for Scotland's House of Care, and we'll close the first session with Alison Hannon, who's an Advanced Public Health Practitioner and House of Care Project Lead. Alison will then hand over to Michelle Watt, who is our Senior Medical Advisor, and Michelle is going to facilitate our first discussion. So now hand over to Nico.
Thanks, Jill. Welcome, everybody. Thanks for joining us today to consider long-term remobilisation in these, I would really say, unprecedented times. I just wanted to share some of my thoughts from a GP and improvement perspective. Now, I do consider myself a glass-half-full person, really trying to see the positives and opportunities in most situations, even during this pandemic and constantly evolving risk situation. Can I have the first slide, please? For me personally, the current situation takes me back to basics and connect with why I do what I do as a doctor, and I'm sure this has been the same for many of you. It takes me back to what quality of healthcare and value really means and could be. Now, obviously, safety is very high on that list currently, but equally high are person-centeredness, effective and evidence-based care, and certainly equity. So how do we adapt evidence-based care to an individual's clinical condition and their values? Can I have the next slide, please? If we consider some clinical examples, we consider Helen, a 30-year-old lady with asthma, well educated about her asthma with a good pragmatic understanding of her asthma management. Now, what is required here? Do we have to recall her? Can we empower Helen, allow her to upload symptom control measures and measurements remotely or whatever way suits her? Can she access the records or some shared interface when she orders her inhalers? Can this even help her decide when to seek medical advice? Or consider Laura, a 60-year-old lady with diabetes, glycated hemoglobin, blood pressure, been relatively stable for the last few years. What's needed monitoring-wise? How often? Traditionally, this was done 6 monthly. Is this relevant to her? What is relevant? Is it our blood pressure, glycated hemoglobin, or ACR? How important are these? Are these important enough to bring her in? Or are there better ways, really, of monitoring her? And finally, consider Andrew, an 85-year-old man, complex multimorbidity, heart failure, CKD, COPD, polypharmacy. I think we can all think of some patients like him. He manages at home with minimal help. Again, what is required management-wise? What's needed? What's important to Andrew? What will make a difference to him? What do we need to make this as safe as we can? Can I have the next slide, please? So as we're remobilising, how can we do this safely, and who needs our attention first? You know, the workload implications of catching up, risk stratifying and working differently are significant. So can we embrace the opportunities of rethinking, redesigning, and still focus on what patients need now? I think we can. The highlighted priority groups are really just an example of what we're focusing on in our practice as we're running several tests of change, trying to learn from this as we're remobilising. The next slide, please. So what can we test? What can we improve in the areas of long-term recall, monitoring and management? Recall systems are crucial. They improve monitoring, they ensure safety, but they are often system-driven and quite rigid. Can we create a personalised, flexible, possibly even patient-triggered recall, considering there's little evidence to apply the previous recall intervals of 6 or 12 months rigidly? But can we do that without sacrificing the safety aspect? What about monitoring? Traditionally done at the practice, but could be done remotely now from a patient's home, at a CTAC location, or if needed at the practice. What would determine this? We will be balancing patient, staff safety, patient preference, convenience. Considering the principles of realistic medicine, can we evaluate what we are testing and why? Why are we rigidly checking annual cholesterols in many patients or an ACR in a 90-year-old? But work with your patients here. speak to your colleagues, compare with neighbouring and similar practices are doing, speak to your local labs who can provide lots of data. What are others doing? Can we learn from variance here? The long-term management really needs to embrace patient-centredness and value. What do we need to move towards real shared decision-making? How do we capture and share information in a format that empowers patients to ask questions and help decision-making? Some of my colleagues will be expanding on this later in this talk. But also, how do we connect and engage with hard-to-reach groups? What is important to them? Some of us might have been aware of some of these groups before, but has this changed in this brave new world? Can I have the last slide, please? Finally, we're very much in unfamiliar territory here. There are huge and not to be missed opportunities, but we need to ensure that what we are rethinking or redesigning is safe. We measure, capture, try and encapsulate that all as you go forward. Involve patients where it's safe, because patients are the experts. Now, share with your colleagues, collaborate locally and nationally, really thinking about the network that Jill referred to earlier on. But we urgently need the IT to help us with this. User-friendly IT to help coding and decision-making. This will help re-establish comparable disease registers and allow us to learn from variation as well as focus on unmet need in our populations. I'm sure this is more than enough from me, and I hope this has been somewhat helpful considering how we could take this forward. I will hand over to Lynn Innes, one of our esteemed practice nurse colleagues and National Coordinator for General Practice Nursing at NES, who will explore the MDT role in delivering person-centred long-term condition care.
Thank you, Nico, and good afternoon. So how does the multidisciplinary team support people in managing long-term conditions? And if we think about our purpose as healthcare professionals is in supporting people in our care to live longer, healthier and happy lives. And this is particularly valuable around how we support people with long-term conditions. Next slide, please. So the Scottish Government's ambition and determination is to achieve the highest quality of care for people living with long-term conditions. And to achieve this meaningfully involves collaborative working across integrated community MDT teams, as well as supporting and growing collective working with specialised services. Achieving this requires even more outstanding communication capabilities and strategies for members of the MDT to come together and support each other in meaningful ways during these difficult times. And this can be achieved and needs to be achieved, I believe, in a spirit of co-design and partnership. To ensure that the highest quality of care is delivered to the right person at the right time, an integrated workforce is paramount, not only to support that person in many aspects, but also building and connecting through trusting relationships within the community to enrich their healthcare experience. And this then enables and develops self-management of their long-term condition. And there's never been a more important time to look at that co-design and partnership than now. Next slide, please. So as we know, long-term conditions are illnesses people live with and manage for many years, which we know are, for example, Nico's already mentioned, diabetes, asthma, COPD, CVD, but also include cancer, mental illness, obesity, persistent pain, chronic leg ulcers, and many others, including potentially long COVID as a new long-term condition, although the data evidence research today is still somewhat limited around that. If we look at the role of the GPN, the role of the GPN is supporting people with any long-term condition is very much based on person-centred care, as without ascertaining what is important or what matters to that person at that time, how are we then able to provide the right care at the right time? It's really important that we have people involved in how we move forward. GPNs are highly accomplished and competent clinicians and ensure that the care they provide is evidence-based and best practice. And the importance of MDT working to ensure that each person has access to person-centred, accurate and appropriate care at this time. The professional MDT relationships can also offer specialised support to each clinician. The knowledge of additional specialist services and where to refer people is invaluable, and we all need to be aware of that and know how to do that. For example, a person with diabetes who has access to community pharmacy service to support smoking cessation, the person with a leg wound that requires specialist dressing is assessed and cared for by the community integrated team, and the person with feelings of hopelessness and self-harm begins conversations with the mental health team. Next slide, please. Many people will come to see us in general practice, and we can offer care that is person-centred, excellent, relatable and understandable, ensuring that we're having what matters to you conversations with people where we ask, listen and do what matters. And this can happen across multiple disciplines. We have a shared purpose, working together seamlessly, providing outstanding care and support to people with complex care needs, and therefore has the potential to improve people's experiences and healthcare outcomes. And this is something we've aspired to for a long time. We've talked about seamless care before, and I think now is the time. And on a very personal note, I have very recently accessed health services for a family member where evidence of the MDT team working together was considered and thoughtful. And as a consequence, the legacy of that experience has brought comfort and joy to what has been a very painful time. But I think we can make that difference, and now is the time to do that. Thank you. I shall pass over to Graham Kramer.
Hello, and thank you, Lynn, and hello to everybody out there across primary care in Scotland. If I could have the first slide, please. Many of you may or may not have heard of Scotland's House of Care programme. It's a collaboration between the Health and Social Care Alliance of Scotland, a NHS Northumbrian organisation called Year of Care Partnerships, and it's funded by Scottish Government. And initially, we had some great support through the British Heart Foundation. And really, fundamentally, it's about helping practice teams enhance the good medical care we provide, with a strong focus on making it easier for people to be much more involved, engaged, and really making their encounters with us as patient-driven and harnessing the full contribution they can bring to their own self-management, what matters most to them. And we've been working with practices virtually right across Scotland. Shetland, we're hopefully coming to you in November. Can I have the next slide, please? Really, what it involves is upskilling healthcare assistants in the medical processes of care. There's all the sort of blood tests, spirometry and foot screening and things like that. And then we then send all that information, this is coordinated by the admin teams in practice, all that information, all these results and things, to the person a week or two before they have a conversation with their practice nurse usually, or their GP. This conversation with their practice nurse or GP can be done by phone, video or face-to-face. And what we find is people are much more engaged, prepared and curious and full of their own suggestions and recommendations. It's a much more productive conversation that they have, and the healthcare professionals are enabled to change their approach to helping individuals set their own goals and facilitating their action and support. So it's a different type of consultation model that we practice, and we call this care and support planning. And the approach seems to result in greater satisfaction and confidence to self-manage for the person, and also a much more increased satisfaction for the healthcare professional. And also results often in improved biomedical outcomes with less medical prescribing and more social prescribing, or what we like to call more than medicine. We tend to apply these principles on a one-to-one basis, but I know later you will hear from Joe Smale in Lothian about how you can adapt these principles where appropriate in group settings too. We have a strong focus on coordinating the person's care into a single process with all their conditions, rather than being disease-specific. Can I have the next slide, please? These are some of the sort of resources that we send out to people, the agenda setting prompts, a little bit of space for them to write their own thoughts and ideas and things they want to discuss. And the next slide, please. And some of the results that we can send out to people, often color-coded and also showing their previous results along with their current results. It's very useful information for them. Next slide. Now, if you want to find out a lot more about this, it's much more than I can cover in a 4-minute brief. There is a webinar really revealing some of the evaluation of the program, and there's a link to that. but also we're doing a sort of Pan-Scotland taster webinar. There's a save the date for Wednesday, October the 14th, and full details of that will be sent out to you in the emails as a follow-up to this webinar. But you can contact me directly. That's my email address. I still have a nhs.net account and also a Twitter handle to the House of Care programme. You'll hear a little bit more about this just now, and I'm going to hand you over to Alison Hannon, who's been leading the House of Care work in Grampian in her role as Programme Manager, and she'll share some of their experience. Thank you very much.
Thank you, Graham. Good afternoon. I thought I would start by showing an overview of the implementation of House of Care across Grampian. So if I can have the next slide, please. Thank you. We've delivered nearly 4 cohorts so far, with the 5th cohort due to commence in early 2021. I say nearly delivered 4 cohorts, and that's due to the fact that we had to postpone the training for cohort 4 back in April and May this year due to COVID. We are looking to pick up the training again next month on a sort of virtual platform with these practices, as well as a couple of other practices that are keen to implement House of Care as soon as possible. Next slide, please. Last year, we published an interim evaluation report on the first cohort of practices that went live with House of Care. These were practices that had fully embedded care and support planning and was operating as business as usual. I was involved in interviewing staff as part of the evaluation. And I do recall speaking to a mature practice nurse looking to retire fairly shortly, and I remember her saying that at the beginning of all this, she didn't really want to go through the whole change process, especially at her stage in her own career. She felt that why should she be changing how she does things now? And I really respected her honesty. And she said that looking back, she feels that it was a really good thing that what happened to the practice in introducing care and support planning. And she feels that she had sort of greater job satisfaction and was making a difference when talking to the patients. And that was really encouraging to hear from her. A key part to a successful implementation is having everyone in the practice to be on board with the changes. There are some significant changes to the administration process to enable that 2-step appointment system, introducing a month of birth recall, invites out to patients, and results letters. However, I feel that we have an excellent e-House support in Grampian. We have a really good e-House facilitator that holds that hand at every step to make those changes in the appointment system and guides them through the IT and the data entry templates that are available to the practices. We have received positive feedback from the admin teams who have welcomed the opportunity to review their current procedures and help navigate the implementation of a new appointment system and proven that it was less painful than they were expecting. Next slide, please. As with all new changes, there are challenges, and introducing care support planning under the House of Care framework works best when you have buy-in from everyone. There is mixed opinion whether chronic disease management should be a GP or nurse-led. Ideally, a multi-skilled team where you have a nursing team that has knowledge and experience of multiple chronic disease works best, but that's not always possible depending on the skill set and the staff resource within each practice. There are day-to-day challenges in each practice, and juggling staff shortages and upskilling staff to review multiple chronic diseases is another. And sometimes it's also the limited physical space within the practice. Next slide, please. The key successes of care and support planning in Grampian is that the patients feel empowered by receiving their results beforehand by post, and this has enabled them to become equal partners in decisions about their care. Nurses have experienced increased job satisfaction. They feel the care they deliver is so much more holistic and makes them feel positive about the healthcare they deliver. From our 6-month review, some of the returned quantitative data highlighted that 95% of patients felt care and support planning helped them to take control, and 77% of patients felt better able to support themselves healthily. On the right-hand side is Trevor, who is a diabetic patient. Trevor sees his annual review a bit like his car MOT, and he likes the traffic light system on the results letter where he knows if he's in the red, he needs to do something about it. And he has a warning amber and green just to see where he is on other areas of his health. And you know, for some people, that's what they need to see it. They need to see where potentially they're heading and to make that decision to do something about it, to be informed and prepared. Next slide, please. Lastly, this is a testimony from Debbie Foreman. She's the lead practice nurse from Kincorth and Cove in Aberdeen City. Kincorth and Cove was one of the first practices to go live with House of Care. I'll just read her testimony. I'm really enjoying House of Care appointments, and the majority of patients are also preferring the new approach. Getting the results before the appointment has taken away the shock factor, and they've had time to process the results before they see me. Patients feel more empowered and leave the appointment feeling really positive and keen to make changes to their current lifestyle and health. I'm now going to hand over to Michelle Watt. Thank you.
Thank you, Alison, and thank you to all our speakers. That was absolutely fascinating, and I've got tons of questions. Really interesting, Nico introducing why is this important, and this idea about person-centeredness, and what seemed to come up from all the speakers and is coming loud and clear through the chat box is that idea of person-centeredness and patients as partners. And change and redesign. I think it was really interesting, Nico asking about personal and flexible and patient-triggered recall, Lynn asking and saying really there's never been a more important time to go design. How do we take this opportunity? This idea of patients as partners and how we design services around them, how things could be person-centered and person-led. I'm really thinking about more than medicine. And I think, Alison, you summed that up beautifully when running throughout everything you were saying to me was a real thing about joy at work, about the satisfaction of having good conversations and feeling that you're really getting in and being able to empower people, which is another thing that's coming up. And there's some really interesting questions coming out through the chat box as well. So Linda raised a question about how do we engage all people with long-term conditions, so not just those with the kind of volume, but how do we really think about personalised, person-centred care for people who may have a range of conditions, and as we all recognise, increasingly more than one condition. Nico, what's your experience in practice, and how have you found managing patients with a number of different conditions? How do you co-design their personalised care with them?
Thanks, Michelle. I thought that was a really interesting question, because it's something we've struggled with for a while as we're transitioning from QoF into this new arena. And the way we've done it is really the hard way. We've identified individual patients and their needs based on historic QoF criteria, but also on other conditions such as chronic pain, some of the conditions that Linda mentioned, the MS people with fibromyalgia, and people on any types of medication really, and looked at when they were last reviewed. And then we started individual conversations and identified patients' needs, and from then on really put on a review based on what we'd agreed with the patient, and then we're in essence establishing recall systems that are far more inclusive that way, because they're not condition specific, but it takes quite a long time, and we've done it partly by searching back and partly by proactively, when patients contact us, having those kind of proactive conversations initially, and when patients request medications or have any other ad hoc contacts with the practice to see what their needs are. Yeah, it's an ongoing challenge, and great thing about a webinar like this is that opportunity to share. And if anybody has got experience or is doing some good work or some learning, then feel free to pop things up in the chat box, and we'll happily collate and help to disseminate any and all information. Sue also raised an interesting question, and a few things came out in the chat box around, should we incentivise patients to be real partners in co-producing and designing care, and by designing, I think you're really sitting down from the beginning and thinking about what matters to me from a person
led perspective and a service delivery perspective, and how powerful would that be if everybody got in the room before the designing actually happened to think about that. And Lynn, I wonder, do you get much opportunity to do that?
Sorry, who was that question addressed to?
That was to Lynn.
Lynn.
To me, sorry. Repeat it again, I didn't quite catch it.
I'm just saying this opportunity to incentivise patients and really involve them in designing services together. And do you have much opportunity or experience of getting to do that, or is it more of an individualised thing as people come in to see you?
Yeah, I would say it's individualised. However, I think that actually about 10 years ago we were doing some kind of work with groups of people, with patients that we're no longer doing. So that kind of seems to have slipped away. Now I know that wasn't across the board, but certainly when I was in practice we were doing that. But I know that doesn't happen now. So I think that's kind of something that was lost and that we need to pick up again and do differently. But I don't think we are at the moment.
Yeah, and I think it'll be interesting as we go on and hear about group consultations, which is coming to the person who asked about it in the chat box. And I'm thinking about how we can do things differently. And the past 6 months, if nothing else, have taught us that primary care is a pretty adaptable and flexible system. It's a bit of an organism, if you like. And how can we support and encourage that flexibility and adaptability with having the infrastructure in place that allows us to do it quickly? And Lorna, you raised a really good point in the chat box about your visits and individualised care planning. They don't necessarily need to be face-to-face. So any of our panellists today, what's your experience of using digital technology like NHS Near Me? How have people liked it? Has it worked for you? Nico, have you used it?
Yeah, Michelle, we've used we've used telephone reviews before COVID, and we're really merging into Near Me reviews for most of our chronic disease reviews. These are obviously kind of multidisciplinary often, so it allowed us to have different people in the room, and sometimes actually we roped family in to allow sometimes elderly and IT illiterate folk to really engage with this, and the feedback was unbelievable. I mean, patients initially complained on the telephone reviews as we're transitioning to that they weren't able to see my face. Not that it's such a pretty sight, I have to say, but on the Near Me calls, people said actually seeing us added so much value and they were able to respond. I suppose the only downside for us was that people brought in lots of additional questions, but I mean our experience has been really, really positive, and was certainly something we're building on at the moment.
Yeah, thank you, Nicole. And I think as Ed in the chat box says, this is really hard right now, and the situation is changing. Again, just this week, things are becoming more challenging yet again. But I think the important message to take from here is how we can keep being flexible and adaptable, how we can respond by really listening to what matters, not just to patients but to staff, to really think about how we improve the quality of experience for the person who accesses the service and the person who delivers it. And above all, as Alison clearly explained, that importance of really encouraging joy at work. And on that note, we're going to move on to our next set of speakers and continue the conversation. And I'd like to introduce Chris Flynn, who's one of our senior community links practitioners with the Alliance, and Joe Smale, a GP down in Lothian. I had the pleasure of visiting down there from a long time ago now, it feels, Joe, and they're doing some fantastic work around group consultations and working to really empower their local cluster. And Prof Brian McKinstry, who's an emeritus GP professor of primary care and e-health, and he's been doing some really interesting work around technology-enabled self-monitoring and person-centred care planning, and I'm sure they'll have a load of thought-provoking questions. Over to you, Chris.
Good afternoon, everyone. It's great to be speaking to you all today. I'll talk to you a bit about the Link Worker programme run by the Health and Social Care Alliance Scotland. Next slide, please. So the programme in Glasgow City, the Link Worker programme, is run by two providers. The Health and Social Care Alliance is one of them, and we have 31 posts across the city. Next slide, please. I'll give you a brief background of the programme. We initially started with 7 practices in the Glasgow area, which has now expanded to 31. So we work within deep end practices where it's recognised that there may be a higher instance of complex health and social care needs. Our interventions with patients are based on one-to-one solution-focused interactions. So we take referrals from GPs, from practice staff, and spend time with the person, really again focusing on what matters to them. What would they like to look at? What would they like to address? And how would they like to do that? Practice development is also part of our role, bringing the links approach, as in looking at the wider kind of social aspects of health into the practice and their development and training, and also community network building. So looking at the community resources that we engage with and engaging with them and sometimes putting them in touch with each other. And that could be from, say, statutory social work services through to third sector organisations in the area and even very, very small community-based groups. Next slide, please. So the linked worker approach in supporting self-management, absolutely led by the individual again. So what does the individual want to address? What's important to them? How do they want to do that? What types of services or resources would they like to access, and how would they like to do that? So the flexibility that we offer is fairly unique in that we have no kind of capped number of appointments that we can offer an individual. We can work with someone who, say, is maybe confident in what they want to achieve and what types of resources in their community they want to find, and they just need some advice, and they can go off on their own and access that resource and let us know how they're getting on. But we can also work with someone who, say, needs some work done on their confidence in accessing services and a bit more time taken to look at what they want to access, what they want to achieve. If they need to be supported along to a community resource, then we can do that too. So we've got no cap on the number of appointments that we can offer a person. It could be very, very few appointments if that suits the person, or more if that suits someone with more complex needs. Ultimately, we look to engage people with services in their local area. So again, that could be from small community groups through to kind of larger third sector organisations that work within the local community of the practice. So the Links approach is complementary in collaboration with other initiatives such as House of Care, when we look at the more than medicine aspect of the House of Care model and recognising the social determinants of health and looking at the importance of social prescribing in order to meet people's kind of wider health and social care needs. Next slide, please. So implementing a Links approach within general practice, obviously that's far easier if you have a member of staff, a Links worker doing that, but the approach itself can be implemented within practice teams, really being aware of what else is in your community, thinking about the conditions that you see and you support people with, what's there in the third sector within your community, are there smaller local groups there to provide ongoing kind of self-management support for people, looking at building the relationships that you have across your MDT and your wider community teams, including the wider statutory services. So you're getting to know the community networks, who's out there, who are the kind of key individuals, what networks do they use, can you feed into that, can you have information passed on to you to really increase your knowledge within the practice of what's happening within the wider community. Next slide, please. So learning to date, after the initial pilot of the Links Worker project in Glasgow, there was a 2017 evaluation report carried out by Glasgow University. Feedback from general practice that we find from the practice team, from the GPs, is that the Links Worker programme has been a fantastic resource, just to add to the number of resources, the type of resources that GPs can rely on and have in their toolbox in order to help people ultimately. Feedback from participants, the main aspect is the time that they're given. Our appointments are all 1 hour long, so people like to be in that familiar environment in their GP practice, but have that dedicated longer time to talk about what's important to them. In terms of learning from COVID-19 and the impact of that, we've moved to mostly telephone-based services. Generally, a lot of support to people who are shielding, and we've fed back our experiences of that and experiences of people that are shielding to Scottish Government. I'll pass you on now to Dr. Joanna Small from NHS Lothian.
Hi. Thanks, Chris. Hi. Next slide, please. So I'm just going to give a brief overview of our experience using group consultations at Trinent in East Lothian. And we came to this model through a project we were doing through the Value Improvement Fund for Realistic Medicine, looking at how we could better support our patients living with long-term conditions in primary care. And it was a lucky coincidence that we met Alison Manson, who runs the Group Consultations organisation, at one of our Protected Learning Time events. So we've been supported with a bit of funding for the training element around group consultations with Alison and also with Rob Lawson from the British Society of Lifestyle Medicine. And I know if you want more information, Alison would be very happy for you to email her directly or to look at the group consultations website. And during the process, we've linked with some other local practices who've looked at this model, including Preston Pans in East Lothian, Sighthill Green in Edinburgh, and Inverkeithing Group Practice in Fife. Next slide, please. So group consultations are an innovative way of delivering person-centred care. We're very lucky in Trinent to have an excellent practice nursing team who deliver a lot of the care for people living with long-term conditions. And in Trinent, we were one of the British Heart Foundation pilot practices for the House of Care in Lothian some years ago. So we saw this as an opportunity to scale up what we were doing with our House of Care work. We'd already adapted our processes to fit with the House of Care. So patients were coming to see a healthcare assistant to have their bloods and markers checked, and then they were getting their results in the post and then coming in for a care and support planning conversation with our practice nurses at that stage. And we thought this was an idea to try and do things slightly differently at a different scale and with the element of peer support which the group consultations offers people. Next slide, please. So just looking briefly at how a group consultation works, typically the session will last for 90 minutes, and it's set up by a facilitator and the clinicians present in the room for about half the total time. And a typical group consists of 6 to 15 people. In a face-to-face consultation, if you've got too few people, the dynamics of the group can be more difficult. Actually, often the more you've got, the better it works. You need to slightly overbook the session, expecting that maybe a couple of people won't be able to make it on the day. And group consultations work well for a variety of conditions, particularly people living with diabetes, asthma, COPD, heart disease. Fraser Burrell has used this model in his rheumatology clinics in the north of England. Next slide, please. So thinking about the main benefits of group consultations, it's really an opportunity to do something slightly differently. It helps bring our team together, looking at how we were going to implement this in the practice with the practice team. We trained up some of our administrative staff as facilitators, and we had some face-to-face learning at the beginning 18 months ago now, and now there are a lot of web-based resources available for additional training. And the majority of patients tell us that they prefer to receive their care this way. There's a couple who feel it's just not for them, but on the whole, people are quite comfortable to talk in a group. People are talking about a shared condition. People will bring up questions that maybe someone else hadn't thought of or had been too embarrassed to ask, and on the whole, it leads to a much deeper understanding of a condition. Also, the clinicians often find greater satisfaction in working this way. Having to repeat the same conversation several times in a day, maybe about how your inhaler works, can be quite frustrating, whereas potentially having to just say it once in front of a group of people can be much more satisfying. And the people in the group will add their own information about things that they've tried that work for them, and other patients will pick up on that. Next slide, please. So naturally, the COVID pandemic has impacted on our ability to deliver group consultations in person, but the model has evolved so that virtual group consultations now deliver most of the same benefits, enabling patients to receive support and advice from each other and their practice during these uncertain times. And the group consultation resources have been adapted so that they now work with virtual groups. Of course, the facilitator is increasingly crucial in making sure that the session runs smoothly, but as we're doing now, there's plenty of opportunity to share resources via shared screen sharing, and getting people to still follow a similar setup to how a face-to-face group would work. And a virtual group probably works better with a slightly smaller group of maybe 8 people, just because of everybody having their chance to say something through a video call potentially. So we haven't started running the virtual groups at Trinent just yet, but we're hoping to in the very near future, and we're tying in with Alison Manson on that. Next slide, please. So one of the most powerful aspects of the group consultation is the shared results board. So this is something which people think, oh gosh, a patient's going to be comfortable with that, but actually, it works surprisingly well. Patients obviously sign a confidentiality agreement at the beginning of the session. Only first names are used, and it's very powerful when you see how your results compare with other people's. So obviously, depending on what the condition is, you'd have various different markers listed, maybe HbA1c, blood pressure, smoking status, cholesterol, and you'd be able to see, the numbers are that bit more meaningful when you compare how your results look with other people. It acts as a focus for discussion, and then patients are encouraged to set their own questions for the clinician before the clinician comes into the room, and also to set their own goals for what they're going to do before the next session. Next slide, please. So that's a very brief overview today. If you want more information, do have a look at the Group Consultations website, or Alison Manson would be very happy for you to email her directly. Thank you very much. I'll now pass over to Brian McKinstry.
Hi, everyone. We're going to have a very quick, rapid ride through telemonitoring, remote monitoring for 5 of the most important conditions. Everything's been turned on its head by COVID, and a lot of the evidence I'm going to talk to you about is comparing telemonitoring with normal care. And of course, there's nothing normal about care at the moment. Next slide, please. So the first one I'm going to talk about is high blood pressure, and this is probably the most optimistic slide. There's no doubt about the fact now that telemonitoring in blood pressure, managing blood pressure, improves outcomes by around about 4 millimeters of mercury systolic, which doesn't sound like much, but that's enough to reduce the stroke rate by 15%, MI rate by 10%. The work that we've done recently in Lothian, when we looked at blood pressure at scale, it has decreased the workload. So in other words, a reduction of 25% in face-to-face appointments. It's really well liked by both patients and clinicians, and 80% of practices in Lothian now using it. Over 10,000 people in Scotland now using it. It's really taking off, and of course COVID has pushed it even further. I'll tell you very, very briefly about Scale Up BP, which is at the moment is supported by Scottish Government Technology-Enabled Care. It's been adopted by 11 boards in Scotland. BP machines are supplied under this scheme, and patients send in their readings, and the general practitioners and nurses get a report rather than having to log on a regular basis. And this report arrives via DocMan, and you can see a little copy of it there. It's very, very detailed. You get an average as well as a tabular and graphical representation of the blood pressure, a very clear exhortation to take action if that is required. It's a real no-brainer. Can we have the next one, please? Diabetes, there's evidence from randomized controlled trials, and see loads of trials here, lots of patients, suggesting it almost produces control, improves patients' control 2 times as many times people achieve control than in control groups. So a very, very effective intervention. It's been more difficult to scale this up, possibly because it's slightly more unstable than blood pressure, and possibly because you still need physical assessments for eyes and feet, and if people are keen on doing hemoglobin A1C as well, that's important, and the home tests for those are quite expensive. But we really need to be rolling this out, and I think that has to be the next big thing that we move with in Scotland. And so it shows fantastic promise, and I think we should implement it. But obviously we need to do this in some sort of evaluative framework to make sure that it works at scale in the same way as it works in randomized controlled trials. So next slide. Heart failure is another interesting one. It's probably put forward as one of the main reasons why we should do telemonitoring. Largely managed, I think, by hospital outreach teams, not so much by general practitioners. Again, the meta-analysis seem to suggest that it works really well, but only for a relatively short time. So for about 6 months, it produces an improvement, and then after that, it's not any better than normal care. But remember, at the moment, of course, we don't have normal care, and we have to keep reminding ourselves of that, and we're comparing this almost certainly against virtually no care at the moment. So certainly, when we do get back to normal working, telemonitoring for heart failure will be useful in, say, in discharge groups or very unstable groups. But at the moment, very, very useful, I think, as a prom, as a way of reviewing people. Next slide, please. So asthma has been a kind of disappointing one for telemonitoring. Quite a lot of trials carried out again using telemonitoring in asthma and showing very little in the way of improvement in emergency room attendances, very little benefit in symptom control, but did seem to work really well for these very unstable asthmatics. And so people who are at risk of hospitalization, it'd be quite a useful one to do. But again, I have to emphasize that we are not comparing this in the current climate against normal treatment. And telemonitoring could provide a very nice prom by which people could assess patients. And of course, using Near Me, we can now check their inhaler technique and look at their peak flows very, very easily. And next slide, please. COPD has probably been the problem child of telemonitoring. Everybody wants it to work, and no one has ever made it work. So in general, the better conducted the study, the larger the study, the less likely it is to show benefit over normal care. Again, I mentioned normal care here. And in fact, unfortunately, in work that we did, a randomized controlled trial in Lothian showed an increased workload with no improvement in outcomes. However, patients absolutely adored it, and with people, accusing me of killing their mother by taking the machine away. However, observational studies using a light touch approach, in other words, using it as a prom, telling patients that when they should get back in touch, so they follow their own management plan, only getting in touch if they run into trouble, but then the data is available to clinicians, appears to work quite well. And there's a very large observation study just taking place in Glasgow at the moment, which is looking into this. And I think this is the way forward with COPD. Next slide, please. So basically, just summing up, COVID does necessitate a reevaluation of telemonitoring because we are not comparing against normal care, but certain things need to be done now. Blood pressure is, in fact, a no-brainer. We should be all pushing forward telemonitoring for blood pressure. Diabetes is ready for implementation. Asthma, COPD, we should consider them as PROMs or aids to review, and heart failure post-discharge. Very happy to take some questions on that because I realize it's quite a romp through the whole thing. Thank you. I think we're on to discussion now, Michelle.
Thanks, Brian. It's Scott Jameson here, GP from Royal College of General Practitioners. Thank you to our speakers, and I think I've now got, just looking at my detailed agenda, I think I've got somehow 5 minutes we've managed to get to roughly the right point to have a quick discussion. And just to tease out some of the themes, and just going through it from the start there to summarise some of the things, starting off with some excellent talk from my colleague Nico at the start there. Cough is gone, but what do you do from here? And I think you need to do something is the bottom line. Definitely not doing cough is a good idea because there's a lot of things about cough which were not helpful, but not evolving and not improving what we're doing in long-term condition care will not help anybody, no less our patients. And I worry slightly that our outcomes may suffer if we've not got a way to show improvement in our long-term condition care. In time, I think from a national perspective, we are looking at how do we share at least the evidence as to what is out there, and we're looking at doing that in a collaboration with HIS in long-term condition care, potentially about how do we share at the baseline, what do we agree is sensible to be doing. But beyond that, we need to be improving our mechanisms, no doubt. It was interesting to hear about the link workers as well and the social prescribers. We're very lucky to have those within our practice. They've been a great asset, and they were provided through the Primary Care Improvement Plan, and a huge asset to the practice to think a bit more laterally. I guess with regards to the House of Care perspective, I think if practices aren't wanting to do House of Care, it doesn't need to be called House of Care per se, but it's about what matters to you care, and it's changing that dialogue from using cough or using data gathering as a tool to then focus on what matters to you, and whether you do that on gathering data through the scale-up BP stuff, through Flow, through MedLink, however you get the data in, It's then using it to then focus on what matters to the person, and whether you, again, as Nico I think was suggesting, they did it on Near Me, or whether you're doing that in person, it's got to again be options opened to patients. I think with regards to, I was just thinking, just spotting in some of the chat about the different things about what are the different options there, about how does that work, or what is it. I think some of the things, Brian, with regards to, it didn't prove that it was better. I don't know if that's what we want to prove necessarily. I think what we want to potentially be moving towards is offering choices. And I think the ability for patients to interact with their practices in another way is a really positive thing. I don't think we should be restricting ourselves to forcing everybody into a 20-minute annual review, as Nico was suggesting. I think offering the choices for how you want to interact is as positive an outcome as any. Designed together, Michelle, absolutely. I'm just going to just turn, we've got a minute before I hand across to Jill for closing words. Do any of my other colleagues who've been hosting or anything want to make any comments? I think this has been wonderfully enriching, and certainly from a clinician's perspective, very much times where the college sits with regards to offering things are important, offering reviews are important. We're trying to avert changes in long-term outcome if we can. SIGN, where I sit on SIGN Council on behalf of RCGP, we struggle to find evidence for what to do. Therefore, offer choices and improve the quality of what we do is really important. Offering consistency, maybe, well, yeah, there are different choices. Consistency of choices. I like that approach, Anne. Okay, does anyone else have any comments before I close and pass across to Jill? No. Okay, Jill, thank you so much. Jill, I'll hand over to you for closing remarks.
Okay, thank you for that, Scott, and I really did like that wee sort of ending term there that you called out around about consistency of choices, and that seems to ring through in a lot of things in and around even potential use of technologies such as Near Me. Can we move to the next slide, please? So just wanted to close by thanking all of our speakers for delivering really insightful, thought-provoking presentations, and also for keeping to time. That was a huge ask. I know there was so much more that they could say. We've popped up some of the resources that were mentioned throughout this afternoon onto the slide here. I think there was possibly some others, and I know Graham certainly called out a WebEx that he's hosting, so we'll make sure that all of those are available. Next slide, please. We will make them available on, and I just wanted to highlight this to you all, on our Improving Together Interactive. We've a dedicated page to these primary care resilience webinars, so if you've missed any, you can go in there and capture any of the previous slides and recordings from previous WebExes from today's. We'll upload the links to all of the resources that have been mentioned, both within the presentations, but also we will capture a summary of the resources and links that have also been mentioned within that chat box, and we will, as usual, send out our evaluation survey. Maybe pop on to the next slide, please. We will send that evaluation survey where we will want again to hear from you what you would like to discuss in future topics, and we'll also send the links to the summary sort of from the chat box and also the recordings. Our next WebEx is aimed for November, so if you can let us know what you would be keen to discuss, and we will try as much as possible to tailor our WebEx to what's coming through strongly. And really just for me to say a final thank you to all of you for joining us this afternoon. I appreciate taking that hour out. I know it's been a rapid romp through, and if you are interested, really be keen to begin to establish that network. There was lots of conversations, so let us know. The evaluation link is in the chat box, and really just thank you and have a good afternoon.
Thank you so much. And everyone, that now concludes the call, and you may disconnect. Thank you for joining.